intensive care. Over to Dr. Muttaya to deliver his talk on management of acute wheeze.
Thank you, sir. In the next 20-25 minutes, we'll be discussing of managing a child with wheeze at the level of ER, emergency room. So to start with, I'll start with some case discussion, then go to the topic per se, just to make it clear for the audience how important it is to identify a wheeze which is not due to asthma. First question which we have to ask ourselves every time is whether a wheezing child is really an asthmatic or we are dealing with something else. So I hope in the next 5 minutes I'll make some points clear in that. First case is a 2-year-old male presented with cough for 1 day with no history of fever, fast breathing for 4 hours with no significant past history, was tachycardic, tachypnic, pulses were well felt, saturation was normal in room air, had a normal sensorium. The child had minimal subcostal retractions and minimal work of breathing. Chest on auscultation at wheeze on the right side with decreased air entry on the left side. So we did an X-ray in this child after starting nebulizations. So this is the X-ray which is showing unilateral hyperinflation. You can see on the left side, and this is actually due to obstructive emphysema due to an airway obstruction in the left bronchus. This actually turned out to be a actually you can see the serial X-ray. Here it is more clear. The emphysema has increased and the right lung field is hemithorax is lung because the pushing of the mediastinum to the other side, the right hemithorax is lung volume is reduced, and subsequently rigid bronchoscopy was done and it revealed a peanut, a piece of peanut. So this is one scenario which is very commonly seen. The second scenario is a 6-year-old male child present with fever and cough for 5 days, had fast breathing and decreased activity for 1 day. Heart rate, he was having 150 of heart rate with tachypnea rate of 40, minimal work of breathing, had bilateral scattered wheeze. Nebs were started. Chest X-ray was taken after 2 hours as there was no response to nebulizations, and a blood gas was done which showed metabolic acidosis. Uh, the X-ray is like this. You can see there is cardiomegaly in this X-ray, and what was missed in the clinical examination was the subsequently the pulses were checked. It was weak. The heart sounds were muffled, and there was in the history there was decreased urine output, and there was a large liver span which was missed. So if we would have identified this, we would have spent a little bit more time. If we go systematically, as Dr. Mullai rightly told, the ABC circulation part was not properly checked in this child to start with. That was the reason why the nebulization was ordered, and subsequently the child took 2 hours to recognize the problem. So the next case is a 4-month-old female infant presented with fever and cough for 3 days, had fast breathing, decreased feeding since 3 days. There was significant tachycardia, tachypnea, significant work of breathing with subcostal, intercostal, and suprastral retractions with room air saturations of only 88%. Chest had bilateral wheeze. Here, the history was little prolonged with fever and fast breathing for 3 days. So we ordered immediately an X-ray, and this showed this kind of an X-ray with bilateral patchy infiltrates and a huge, it's not looking exactly like a thymic shadow, but something fishy there. So the subsequently the X-ray and CT, you can see there is a airway narrowing due to enlarged lymph nodes, and there is carinal widening. You can see the left main bronchus almost obstructed. There is a like lower trachea narrowing. All these are due to a TB infection. Like the mother of the child was having TB sputum positive, and subsequently the child acquired TB. And these were lymph nodes obstructing the airway from outside. Third, and the other case is a 3-year-old male child presenting with fever and cough for 3 days, difficulty breathing since 6 hours. Here again, tachycardia, tachypnea, significant tachypnea, child is hypoxic, and there was decreased bilateral air entry on auscultation. The child was unable to lie on bed even with mother. There was a paradoxical breathing pattern. Child was almost with air hunger was moving both the lower limbs, had a bad air hunger, identifies mother but unable to speak. This was the status at ER, and the child had no similar illness in the or significant illness in history. This is a classical X-ray of a wheeze associated LRTI. Here, this child is bound to respond to nebulizations and IV corticosteroids. So one thing is common in all these four cases. All these four cases received nebulization with acetylene in the beginning with oxygen. So the first question is it wheeze due to bronchiolitis or asthma? And we need to rule out the asthma mimics. Any sick child, so wheezing is not synonymous with asthma. So any sick child who's hyperventilating could be having DKA, could be having any problem, septic shock, hyperventilating, may have wheeze. So it doesn't mean we have to nebulize any child with metabolic acidosis. Entities which can present with first wheeze at ER are important to identify and treat. Like the routine ones are like asthma, viral illness associated wheeze. The other ones are like pneumonia, foreign body aspiration, heart failure, or even viral myocarditis, are to name a few. The others are airway obstructive causes, obstructive airway lesions. Like some may be fixed, like airway hemangiomas, lymph nodes, or vocal cord dysfunction. Some may be dynamic, like the routine laryngotracheobronchomalacsias and vascular slings, which obstruct the airway. So coming back to our topic of the discussion, a 8-year-old female known case of asthma with history of poor compliance and 18 hospitalizations with 8 PICU admissions came to ER with another exacerbation with heart tachycardia, tachypnea, increased work of breathing, and bilateral air entry decreased. Child saturation was 90%. She was able to speak few words with normal sensorium. The blood gas was normal. The peak expiratory flow rate compared to her personal best was 50%, and she was not responding to initial back-to-back nebs and IV steroids. So what next? So here comes the discussion. Status asthmaticus is a common emergency in children where we see progressive worsening of the bronchospasm with associated with respiratory dysfunction, and which is unresponsive to our conventional therapy of nebulizations and IV steroids and oxygen, nasal oxygen alone. And the problem is it may progress to respiratory failure if unattended quickly. So the ABC of asthma is, just for remembrance, airway hyperresponsiveness reacting to overreaction to some triggers, environmental, bronchospasm leading on to bronchospasm, and there is a long-term chronic inflammation in the airways which lead to some airway remodeling. So this is how the airway looks in the asthma compared to the normal airway. It is narrowed and there is mucosal hyperplasia and everything. So you can see there in the asthmatic lung, you have unexpected airways. There, in some areas, there is some mucus plugging going on in some places. There is airway narrowing and there is inflammation at other zones. So it is a heterogeneous lung disease. In a like after exposure to some environmental factors, in a genetically predisposed, they can present to a acute present with acute exacerbation. So in early bronchospasm, the bronchodilators work. In later phases, where inflammation predominates, anti-inflammatory drugs work. So we need to do rapid cardiopulmonary assessment in the ER, as emphasized by Dr. Mulla in his previous talk. We need to do the rapid assessment, triangle, airway, breathing, circulation, and primary assessment, pentagon, following that. A, B, C, D, E. So this has to be done rapidly within a minute. At the same time, history. To confirm the diagnosis, we need to ask the time of onset of exacerbation, potential triggers, severity of symptoms compared with the previous exacerbations, because that determines the risk, and the response to treatment prior to admission. And in examination, we need to assess the severity to start the treatment. The SpO2 is part of the initial assessment. The level of alertness, hydration status, presence of cyanosis or pallor to identify respiratory failure, and the respiratory distress quantification is important. Wheezing and decreased aeration is another thing which we identify in physical examination in most of these patients. And at the same time, we need to identify complications mainly related to air leak, and also rule out upper airway obstructive causes like croup and foreign body, which is not at all uncommon. So the respiratory mechanics, just a word on that. We all know during expiration, the intrapleural pressure is slightly high, which leads to more narrowing of the airways during expiration. So the airway narrowing, increased resistance in the smaller airways of children, a bit reduced flow. This all makes the expiration become a more active process, leading on to some work of breathing. And with more and more air trapping in the lungs, the diaphragm flattens and the expiratory muscles cannot contract properly. There is some amount of BQ mismatch, that is ventilation perfusion mismatch, mainly due to the shunt. The child breathes fast to compensate. There is hypoxemia, but hypocarbia initially. And once the patient goes in for respiratory fatigue, there will be hypercarbia as well as hypoxemia. So this is how the lung air gets trapped in the alveoli. You can see the FRC keeps on increasing with time, and there is some amount of pressure trapped, intrinsic PEEP we call, in the airways. So, what are the risk factors for a severe illness or a severe exacerbation? Past history of PICU admission, history of rapid deterioration, or mechanical ventilation in the past, preterm NICU graduates and children and babies with chronic lung disease, where they are exposed to prolonged oxygen exposure, they are at high risk. Psychosocial factors, ethnic factors, denial from the parents, poor compliance to treatment, high allergen exposure are all risk factors, along with genetic factors. Obesity and older age of children is an independent risk. And pulsus paradoxus at presentation is another important risk factor. So how do you triage a child with wheezing? So the more important to identify the critical children where there is wheezing with severe tachypnea, bradypnea, severe retractions, with grunting, and sensorium becomes drowsy or lethargic clinically, and there may be silent chest and a desaturation below 90%, the peak expiratory flow below 40% if you have the baseline level, and the child will be able to speak only words if it's a verbal age, if beyond the verbal age. And in other scenarios, like it may be wheezing with moderate, like milder variants are like moderate attack with increased work of breathing, nasal flaring, tachypnea, some amount of retractions, prolonged expiration, and agitated sensorium with saturation below 92. This also needs immediate attention. And asthmatic with history of intubation becomes an independent risk for severe illness, and the child here will be able to speak few phrases. And another acute scenario is where there will be a mild work of breathing with tachypnea, some amount of retractions, peak expiratory flow between 40 to 70%. The child may be agitated, but here the child will be able to speak sentences. So here it is compared to a mild to moderate attack. The emergent and critical triage goes to severe critical thing, immediate severe attack, and the urgent and less urgent goes to mild to moderate exacerbation. So in less urgent phases or mild cases, you will have a normal saturation with tachypnea and wheezing will be there. And another important clue is the child will be preferring to sit in an upright position, and there will be in the history difficulty or refusal of feeds. Remember, saturation will help us to grade the severity, but it will not help us to identify the response to treatment. And blood gas showing the PCO2 or ATCO2 doesn't grade the severity. So there are various scoring systems. I'm not going to go into details, but the one which is validated is the P-School Respiratory Assessment Score, or the PRAM score, where they take into account the retractions, the work of breathing, the air entry from normal to absent, wheeze, which is only in the end of expiration, to both during inspiration and expiration and audibly seen, and the SpO2 being normal going up to below 92%. Based on that, we score it. And there is another score which is again commonly used, which is modified Woods and Downey score. Here the addition is the CNS disability scoring, where if the sensorium is agitated or depressed, they get a higher score. So at the ER, we need to, as based on an asthma score and severity, if it is mild, a salbutamol puff. In this COVID era, we are all afraid to do nebulizations. Even a salbutamol puff may be equal with a spacer, may be equally efficacious in the mild case as does the nebulization of salbutamol alone. In a moderate scenario, you need to start continuous or repetitive nebulization salbutamol, or what we call as back-to-back nebulizations at least 3 times within 1 hour, along with oral or IV corticosteroids. This is to prevent it from further progressing. And if the child is presenting with a severe attack, we need to start continuous nebulization salbutamol with oxygen, and intermittent nebulization ipratropium 3 times in the first hour. IV corticosteroids is preferred here. IV Maxelf can be considered early, and other interventions based on the risk factors. And here we need to inform and alert the PICU team. And what are the severe findings at admission? Severe retractions, low saturation, diffuse wheeze, paradoxical thoracoabdominal pattern with lethargy, diaphoresis, unable to speak, and altered mental status. All these becomes high risk factors. And silent chest is an ominous sign. Asymmetry of wheeze, remember foreign body or complication with local atelectasis or air leak syndromes, where there will be associated crepitus also. So recognizing and triaging at severe cases at ER and rapid aggressive care will interrupt this vicious cycle of air trapping and prevent respiratory fatigue and avoid mechanical ventilation. So the important thing in ER is the nebulization. Most of the time, the non-responsiveness is due to poor nebulization aerosol delivery. Adequate metered dose inhaler with spacer puffs at home also is a question mark in an attack, because the cooperation from a crying child is always a question mark. In fact, the nebulization deposition in a crying child is unknown. The proper dose in a proper carrier solution, at least 3 to 5 ml of normal saline is ideally the carrier solution, with minimizing the interruptions is very important for proper response. Proper technique, the vertical position of the chamber with good fume generation. Nebulization always with oxygen, free flow oxygen 6 to 8 liters to prevent or treat hypoxia. And at the end of nebulization, at the end of 10 minutes, there should be only less than 1 ml of nebulization left. So that is again to say whether the nebulizer is working properly. Another common thing what we see is worsening hypoxia when we start salbutamol nebulizations alone. What happens is normally the airway is narrowed, and the physiological response is hypoxic pulmonary vasoconstriction. So the blood is diverted to the normal zones to maintain the BQ mismatch. But when we start salbutamol nebulizations, the blood gets the blood vessels get dilated in the areas of poorly ventilated alveoli also. The airway is still narrowed, but the perfusion is increased there. Thereby, stealing of blood from those well-ventilated zones happens, and this leads to worsening hypoxia when we start. That's why we always advise to start salbutamol nebulizations in a sick child with oxygen to prevent this problem. So for a mild attack, always even salbutamol puffs based on the weight, you can give 4, 6, or 8 puffs along with oral prednisolone is always required. But in a severe scenario, continuous nebulizations, again, based on the weight, we have the dose ranges. Here again, IV corticosteroids will be preferred along with ipratropium bromide and Maxelf. Remember, if IV access is getting delayed, subcutaneous adrenaline or terbutaline is life-saving in a severely life-threatening hypoxia or a silent chest, and even IM steroids may be equally efficacious to oral or IV steroids. When we are waiting for getting the IV access, remember all painful procedures may exacerbate bronchospasm. So repeated assessment is the key in the ER. Assessment every half an hourly for the first 4 hours is the key based on the severity, respiratory score, and consciousness. Heart rate, respiratory rate, SpO2 should be monitored. And at the end of 4 hours, we determine whether the child requires ICU care or ward care or discharge. So this table, you can just take a screenshot just to tell you the weight based on the weight bands, the requirement of dose. Generally, 1 ml of salbutamol has 5 mg, and 1 ml of ipratropium rescue has 250 mics. And continuous salbutamol nebulizations here means 0.5 milligram per kg per hour to a maximum of 20 mg per hour. And steroids, maximum oral prednisolone and methylprednisolone we gave up to 60 mg. And dexamethasone, based on weight, we don't give more than 8 mg as a start dose. Dexamethasone, actually, for sorry. And another important thing is the puff versus neb ratio. 4 puffs is equivalent to 1 aspirin neb, and to get the same effect of aspirin in oral, we need 20 times the doses nebulization. So we all know local route is preferred to avoid unnecessary side effects. But again, the deposition of the nebulization in a narrowed airway is a question mark. So sometimes we resort to oral or IV routes also in a severe attack. So steroids, any steroid can be used, but we need to know the duration of action and the dose. It's unit-based protocols. We prefer dexamethasone. Some places they may prefer methylprednisolone or hydrocortisone, and the doses are given along with the maximum doses. So Maxelf is again a useful drug. It's a bronchial smooth muscle dilator at the dose of 50 milligram per kg, which is equivalent to 0.1 ml per kg of 50% Maxelf with a maximum dose of 2 grams. That is 4 ml given over 30 minutes to 1 hour. Terbutaline, again, subcutaneous or IV route is preferred, and infusion is preferred, starting with 0.4 mics per kg per minute up to 2 to 3 mics per kg per minute. Very rarely used, only used in ICU setting because there are a lot of side effects and monitoring needs to be done continuously. Ketamine, again, very rarely used, only in the ICU setting. Aminophylline, again, in places where terbutaline is not available or the patient requires continuous infusion. It's again a rescue drug. Loading dose of 5 mg per kg over 30 minutes to 1 hour is given.
Dr. Muthaiya, 5 minutes left.
Okay, yeah. So, and again, infusion is based on the weight of the infant, and therapeutic drug levels have to be monitored. So I'm just going fast in amount of time. So that based on the good treatment, based on the response, we analyze whether it's good or poor. If the wheeze is settled and if the child is clinically improving with improving respiratory distress, we can very well discharge the child or observe the child in ward. If the worsening despite giving proper nebulizations and steroids, if the respiratory distress is worsening, or if there is access, if there is increased use of axillary muscles or worsening saturation, then we have to escalate the care to PICU. Here, I'm not going to dwell too much in the respiratory support which we give, because there is a separate talk on that. I just want to say NIV, early use of NIV in these patients is very helpful. It's an alternative to conventional mechanical ventilation, but it remains an unproven therapy because lack of evidence is there in children. But prior to intubation, it is very its trial of NIV is important, is a mandatory. Because a lot of benefits of NIV, like decreased need for intubation, because no one wants to intubate a wheezing child, improve the alveolar ventilation, improve gas exchange, relieve the dyspnea, and improve the work of breathing, resting by giving rest to the fatigue muscles, and it decreases the length of stay. And high flow nasal cannula is what is the preferred mode which we use. The interface is comfortable and can be used in the ER. It flushes the anatomical dead space, thereby reducing the inspiratory demand, and it extends the upper airway, thereby reducing the resistance and work of breathing. And NEPs can be easily provided with NIV compared to other modes of NIV like BiPAP or standalone NIV ventilators. You can see the NIV, the doses I'm not going to details. This is how we provide NIV previously, and nowadays we have this inline nebulizations. The advantage of this vibrating mesh nebulization is it maintains the laminar flow without reducing the flow given to the patient, and the temperature and FiO2 is better maintained, and there is better entrainment of the nebulization gases and enhanced delivery of the gases. So you can see these are the various delivery devices and the connections. The airvo which we all are familiar with. This is where the new circuit we connect the nebulizer chamber to the wet side of the humidifier chamber before the initiation of the circuit over here. So I'm not going into details of this NIV settings. Basically, we start with ST mode or pressure support ventilation in the NIV ventilator. Give a good IPAP and EPAP as per tolerance. The interface should be properly fit, not too tight, not too loose. IPAP is usually maintained 5 to 7 above the EPAP, and EPAP we usually EPAP is like CPAP or PEEP. We start with level of around 5, and FiO2 based on the saturation to keep it above 92%. And always we try to avoid invasive ventilation because endotracheal tube can aggravate bronchospasm, and there is a lot of serious complications associated with ventilation like pneumothorax or even later on VAP. But at the same time, timely institution of assisted ventilation is important if the patient is failing conventional measures or NIV. The indication for ventilation is cardiorespiratory failure, refractory hypoxemia, deteriorating consciousness with coma, respiratory fatigue, significant respiratory acidosis with pH falling below 7.15, despite NIV and aggressive pharmacotherapy. And the decision of ventilation should be based solely on the clinical criteria rather than one specific ABG value. And again, intubation preparation is very important in the ER. It's a high-risk intubation and expert personnel is required. The drugs, when we exhaust the second-line drugs like terbutaline, aminophylline infusion, we sought for intubation if there is no response. And equipments, we always prefer to use a larger tube to reduce resistance. RSI drugs like midazolam, ketamine, neuromuscular blockade is important, like vicodinium, rocuronium is preferred along with fentanyl, and other invasive monitoring devices are important once the patient is shifted to ICU. And at the same time, we need to monitor the side effect of drugs. For want of time, I'm skipping this. And the discharge criteria is requirement for like the beta agonist salbutamol NEPs should be reduced. There should be no requirement for beta agonist in the last 4 to 6 hours, and there should be no signs of respiratory distress in the child. The saturation should be maintaining above 94% in room air with good air entry, and there should be no risk factors, and the child should be nearby to follow up if there is a problem. If these criteria are satisfied, then you can like even discharge the child, but we need to follow them up. And again, there is no role of nebulized Maxelf, long-acting beta agonists like formoterol, salmeterol, long-acting antimuscarinic agents like tiotropium, or nebulized steroids in the acute scenario. Again, ketamine can increase secretions, and aminophylline is used only as a rescue in impending respiratory failure. Other unproven therapies in asthma is like antibiotics. If there is a high suspicion of secondary bacterial infection, we may use antibiotics, but mucolytics are not proven. Chest physiotherapy may be helpful in the later part of the treatment. Manual compression, again, unsure. Leukotriene antagonists like montelukast and zafirlukast are again not proven. Bronchoscopy when there is persistent collapse. And again, very important to prevent an exacerbation and is of vital importance to prevent such an episode. Parental education and child training, ensure good compliance of preventer therapy, avoidance of triggers, exercise which may trigger an attack, peak expiratory flow monitoring, fractional exhalation of nitric oxide monitoring, lung function, asthma diary are all important. Early MDI relievers at home will prevent a further progression. Early oxygen, steroids with SABA is what I want to emphasize. And refer to pulmonologist to prevent further episodes. To summarize, ruling out asthma mimics early is very important at the ER. Early assessment of severity and aggressive stepwise timeline sensitive protocol leads to quicker recovery and avoids complications. Continuous nebulizations with beta agonist, early steroids will prevent worsening. Ipratropium bromide has a role in severe disease and reduces length of stay. Chest X-ray blood gas has no role in the management, but it will help to rule out alternate diagnosis and helps in monitoring the treatment as well as the complications. We have to catch non-responders early based on history, risk factors, and treatment response, and escalate the care to PICU. Avoid invasive ventilation as much as possible by instituting early NIV. Thank you.
Thank you, Dr. Muttaya. You can stop sharing your slide. So